Onc Live Insights is a video editorial program produced by Onc Live.
Screening for pancreatic cancer has been a challenge for us for a number of reasons. One of them is that we don't have very good screening tools, although we have improved very much in terms of the imaging techniques we have, CAT scans, MRIs, and also in terms of use of endoscopic ultrasound. However, the real challenge here is that who do you screen? Do you screen everyone who's over age of 40, 50? Do you screen every individual with newly diagnosed or existing diabetes? We don't really have good feel for who's really the very high-risk individual in the community, so that we can go after those patients to screen them. And patients with diabetes, for example, some people said, well, if someone is middle-aged or older, develops new-onset diabetes with no history of diabetes in the family, there's someone who you may want to screen for pancreatic cancer. But at this point in time, we don't have really guidelines to apply that sort of strategy with our individuals or subjects in the community who have diabetes. And to me, it's really important also to say that screening creates its own problems, and in a situation where we haven't proven how we can approach this in terms of selecting individuals, it can create more problems because of the false positives we see. When you start doing a lot of scans, and even if you do endoscopic ultrasound, which is maybe a bit more specific at looking at the pancreas, you end up with cysts, you end up with inflammatory changes in the pancreas that can mimic cancer, and that can create a lot of challenges, anxiety with the individuals who have been screened, and also a lot of tests that will be done as a result of that. And on the whole, really this tells me that we're not really anywhere close to having a screening program for this disease. Hopefully we will have more information as we develop more tests that are maybe less invasive, like blood tests, the serum tests that can look at proteomics or other molecular abnormalities like circulating nucleic acids that can be analyzed, and maybe that can tell us more about early detection. But certainly the screening of individuals who at this time we're trying to do similar to what we do like with mammograms or colonoscopies, we're nowhere close to having that done. Now, having said that, there will be individuals who are at high risk because they have family history of certain cancers, or they may be carrying a gene that can predispose to pancreatic cancer. Those individuals who really comprise a very small number in the community that at least we know of, those are the people who there is a trend in terms of having them screened, but screening here is more like doing, again, the things we do for diagnosing the cancer, like the CAT scan or an MRI, and although most people will say doing an endoscopic ultrasound, but still, we don't know how do we do it. We do it every 6 months, every year, and again, the problems we have, the challenges of the false positives that we have to deal with.
So screening for pancreas cancer remains a research question. None of the major societies, routinely recommend this. Having said that, in certain populations, for example, the BRCA subgroup, in families where there's been several members of the family with pancreas cancer, people who have other risk factors for the disease in terms of single gene mutations, for example, HMPCC, people with some other genetic subgroups could be considered for screening. I would say there isn't a consensus in terms of what's the optimal test, what's the frequency of that test, what age to start at, and these are all questions that are being asked. Certainly non-invasive imaging is a core start point, and MRI is the major tool that's used because of no radiation exposure. That's the big benefit over CT and screening healthy patients for potentially many years. There have been adjustments of MRI, like using secretin-enhanced MRI. Not clear that that's a better way to go. if an abnormality is identified, that can prompt an endoscopic ultrasound and direct assessment of the pancreas. Some screening programs will routinely incorporate in their very high-risk patients routine endoscopic ultrasounds alternating with MRIs. So they would be some of the kind of key tools. Things like history, physical examination, CN99 are all crude, and they, for the most part, are not helpful in terms of true early detection. And the big challenge is what to do with the findings, recognizing a lot of times they're findings of uncertain significance, whether they should be followed, whether they should be acted upon, recognizing that you are committing a patient to potentially a big intervention in terms of sacrificing their pancreas if you see something that's of potential concern in an otherwise healthy individual who's deemed to be at high risk for pancreas cancer. So not easy decisions to be made, and not clear guidelines yet, but a lot going on, and almost all the major centres to some degree are have screening programs and are collaborating on this question.